Good afternoon, ladies and gentlemen. Welcome to this new segment of Medcast, your new gateway for the medical trends and updates. Our special segments highlighting cutting-edge development in the medicine field. Today, we are joined by an expert in interventional radiology, a specialty that uses advanced imaging techniques to diagnose and treat patients minimally invasively. Our guest, Dr. Mohammad AlSayegh, is here to discuss how interventional radiology can improve patient outcomes, shorten recovery times, and often eliminate the need for more extensive surgeries.
Welcome and thank you very much for having me.
We are so pleased to have you today to discuss the latest technologies regarding the interventional radiology, which I think most people think this is a new field to medicine. Is that right or not?
The field has been there since the 1970s
Mm-hmm.
with a lot of advances with radiology. So, what was happening is that there were huge jumps in radiology with CT scanners performing better, with fluoroscopy being more clear as imaging,
Mm-hmm.
and with exposure times being shorter.
Mm.
This helped a lot radiologists doing their jobs at a shorter time with less exposure to the patient and to the doctor himself, the physician.
Mm-hmm.
So, the latest things that were happening now, currently, are spinal cord stimulators being updated, upgraded, and research has helped a lot with the gaps around the years.
Okay, that's so great introduction for the let's say the term radiology in general, but still people feel confused about the term, the specific term, which is interventional radiologist. Could you please explain more to our audience what is interventional radiology?
So, interventional radiology is the medicine of using imaging
Mm-hmm.
in guiding minimal invasive surgeries.
Mm-hmm.
So, what happens is using ultrasound or using CT scanners or using x rays as videos, which we call fluoroscopy, guide the doctor to reach the correct position,
Mm-hmm.
be it an artery that is punctured, be it a spine nerve that is compressed by a herniated disc, or be it a bowel perforation.
Mm-hmm.
So, what happens is when we image, we know exactly where to go. Usually, we use very small needles to reach the correct position or structure, anatomical structure. Once we reach there, we confirm our site by using contrast.
Mm-hmm.
Contrast is something very dense that appears very solid on our imaging. So, images being grayish or whitish, the contrast will be a lot darker.
Mm-hmm.
So, we know by the anatomy of the contrast how the structure looks. Once we know, we introduce our needle further into the structure and deliver the correct management. So, if we want to stop the bleeding, we can put some type of glue that would heal the puncture site.
Mm-hmm.
Or if we want to cure some type of aneurysm in the brain, let's say, we can have a stent there or a coil which will heal the aneurysm and direct the blood flow correctly.
Mm-hmm.
In the spine, what we do is approach the nerve and target the region around the nerve. It is called the epidural space. So, the region around the nerve, and we can either inject it with an anti inflammatory medication or we can make the disc shrink that is near the nerve.
Okay, that's very great speech. And before getting into more details into the spine pain management, can you please explain for the audience what is the difference between the interventional radiologist and the diagnostic radiologist?
Yes, so interventional radiology always comes after diagnostic. Anyone doing his residency in radiology is
Mhm.
usually diagnostic,
Mhm.
pure diagnostic. So, what happens in diagnostic radiology is learning how to read anatomy on an image. And that's not easy because anatomy is 3D, right? And conceptualizing this in a 2D manner is something to grasp.
Mhm.
So you need years of training to know every single part of the body. Once you know your anatomy, the second step is knowing the pathology,
Mhm.
the things that can happen wrong in this anatomical structure, be it a bleeder, or be it a cancer cell, or be it an infection, let's say. So after knowing your pathology, and then you can read the image write your report, and deliver this report to the physician. So this is diagnostic radiology in a nutshell. Interventional radiology comes as a fellowship. So after you finish your residency, you get your boards, you get certified, you do your fellowship specialized in interventional radiology. And you have to have a very good background in diagnostic radiology to go further into intervention. Intervention needs skills, so it's hands-on. It's not like diagnostic radiology, which only has ultrasound as hands-on. Once you do interventional radiology, you learn multiple techniques of either puncturing the correct structure or delivering the correct medication and learning a lot of clinical oriented decisions.
That's very great from you. Now, let's get back to the spine management or the spine pain management. How common is the spine pain we have in our society, and how do you use the your field to treat spine management? Oh, sorry, the spine pain.
So what happens is in the society here is patients that have back pain are 1 in 5. This is very common. So it's 20% of the
20%, yeah.
population. If you want to measure it internationally, it's a bigger number over a lifetime. So it's about 60% of people would have back pain once in a lifetime. Once they have back pain, they usually manage themselves. A lot of people don't seek medical advice.
Yes.
But after seeking medical advice, it's usually excruciating pain, very tough pain. They cannot manage themselves. And after that, they get painkillers, pain relievers, some stretches, some physiotherapy, be it through orthopedics, be it through GPs, family physicians, or be it through rheumatologists. After that, if pain is not managed within the first 6 weeks, the pain tends to be a little concerning. So we look for red flags. If the patient has fever, this is very concerning. Is there an infection? If the patient had trauma, is there a fracture that's underlying? If the pain is associated with history of cancer, it might be a metastatic lesion, something
Yes.
that spread from the cancer itself to the spine. So these are the concerning clinical histories. On examination, we look for weakness. We look for loss of anal tone in physical examination. So these are the two most concerning things. The next thing is referring the patient to interventional radiology or to pain management. Our role is saying, does this patient really need a procedure by an interventional radiologist?
So in this terms, you can't call it a surgery.
We usually call it a procedure. We don't call it surgery because it is minimally
Yeah,
invasive, and we don't use blades. So we don't cut the patient, we puncture the skin, until we reach the correct site.
that's great.
And this helps a lot with recovery, as you have brought in your introduction. So choosing the correct patient is key. If the patient has a huge bulge in the disc, or if the patient has some cancer metastasis, this patient should be referred to the correct physician. But with very small disc bulges, with osteoarthritis, which is loss of the cartilage in the spine and rubbing bone to bone, these patients can be managed very powerfully through our management.
Okay, that's very great and fruitful from you, actually. But there are some patients still feeling frustrated of being transferred to like interventional radiologist because they think there will not be any positive impact by their procedure or intervention, as you have said. Now, what advices you could give to the patients in order to, let's say, direct them to the interventional radiologist?
So what happens is it's a multidisciplinary approach. What happens is we have a discussion as physicians. Will this patient benefit or not from our management? Selecting the correct patient, as I said, is key. So just notifying the patients that this service is available. This service will help you recover sooner than you would expect. So a usual disc of medium to minimal size recovers spontaneously in 90% of patients within 7 months. But would you want to wait 7 months and have zero function in your life? It's very terrible
Yeah,
having
surely not.
pain shooting from your back or down your leg, or from your neck down your arms. It's very difficult functioning in society and your job as a part of a family,
Yeah.
So, what happens in interventional radiology? The procedure usually takes 5 minutes up to 30 minutes, after which the patient can leave the hospital within 1 hour. This is very different from surgery, which usually has a higher impact of surgical procedures. So recovery time is much
Much
longer.
longer, yes.
What happens after the procedure? The patient usually rests at home only for 1 day. Second day, he can start work again. Improvement usually takes about 3 days up to 14 days. So it's a very short time of recovery to get end results.
And how long would you expect that improvement would stay with the patient?
If the patient goes through a physiotherapy, patients improve dramatically for a very long time. Osteoarthritis is a chronic disease.
Yes.
So if you have osteoarthritis, you're talking about 1 to 3 years, which is really good for patients that would have back pain for a long time.
Yeah.
And it would avoid a surgery. A sciatica pain, on the other hand, can be treated completely using interventional radiology techniques. So, like a transforaminal injection, which would take about 5 minutes, would kill the pain forever if the patient deals with the cause of pain to start with. And the cause of pain usually is weakness of the back muscles needs strengthening after the procedure. So we usually advise that after 2 weeks from the spine procedure. Patients that are overweight need to lose weight.
Yes.
So if the patient is part of my team and is willing to help himself, he would have a complete solution using interventional radiology.
Rather than going into a surgery.
Very
Dr.
true.
Mohammed, this could be my very last question, and I need the answer to be either yes or no. If the patient is having the pain back again in 1 to 3 years, as you have mentioned previously, can he do the procedure back again with the interventional radiologist?
Yes, the procedure can be done again within 6 months from the first.
Oh, that's very great. I know there are so much details about the spine pain management by using the interventional radiology, so that we are hoping to have you again in our program. Hopefully, we can see you later and discuss more about the spine management.
Thanks again for having me here.
Thank you very much. Our dear audience, we have reached to the end of our segment. Hopefully, we can meet you again with another medical specialist. Until that time, see you later.